name also.
Can you start?
So welcome to the webinar on high risk localized and locally advanced prostate cancer. We have three international speakers. We are very lucky to have three international speakers, and all three international speakers are renowned and dedicated, and they are well known, and they are extremely good. So we are going to have a very good session, and we also have another invited faculty from radiation therapy, Dr. Gagan Saini. And before I welcome the guests, I would actually, because this is a virtual meeting, I would like to invite our hosts, because this is an activity of the North Zone chapter of Urology Society of India. And right, this one has been organized by Dr. Anoop and myself, and Dr. Sudhir Rawal is the incoming president next year of the North Zone. And the other council members of the North Zone are Dr. Anil Ellens, the immediate past president, Dr. Vijay Bora, Dr. Nachiket Vyas, Dr. Harvinder Pawar, Dr. Swapan Sood, Dr. Pawan Kesarwani, Dr. Hemant Goyal, Dr. P.P. Singh, Dr. Anil Goyal, and Dr. M.S. Ansari. And North Zone is actually a part of the Urological Society of India. It's not an independent body. And so whatever activities we do, they are always under the umbrella of Urology Society of India. And on behalf of the North Zone, I welcome Dr. Anant Kumar, the president of Urology Society of India, and Dr. T.P. Rajiv, who is the honorary secretary of the Urological Society of India. And on behalf of all these hosts, I once again welcome the invited faculty, the three international faculty, Dr. A.K. Hemal, Dr. Vipul Patel, and Dr. Bernardo Rocco, and the national faculty, Dr. Gagan Saini. And Dr. Sudhir Rawal is also a part of our team, and rest of us will also be joining in between, and the program has been circulated. So first of all, I welcome Dr. Sudhir Rawal. Dr. Sudhir Rawal is going to speak on the current status of radical prostatectomy in locally advanced prostate cancer in India. The Indian perspective would be presented by Dr. Sudhir Rawal. Dr. Sudhir Rawal, please.
Okay, I'll just share my slides. It's not, yeah, not, no. Can you see them or not yet? No.
Please click the
No,
share.
your slides are not seen, Dr. Sudhir Rawal. No.
I'll.
And I'll request everybody to keep one's mic on mute unless one is speaking. Whatever question one wants to ask, one can send it, type it, and send it.
I'll share it again.
We already have an attendance of 127 participants, and I'm sure by the time the thing hots up, we will have about 400 to 500
Can you
participants.
See no, sir, we cannot see. Just click on the PPT also, sir. Can you click on the PPT also?
I'm on PPT also.
Okay.
It's not coming. It used to come always.
The number of participants has already gone up from 127 to 130, and I'm sure we'll have about 400 to 500 participants within a few minutes.
Is it there now?
Yeah.
Yes, now it has come.
Yeah. So, okay, thanks a lot, Amlesh, and Good evening, everybody, including international faculty, Dr. Himal, Dr. Bernardo, and Dr. Vipul. This is actually a segment of prostate cancer, which is more treated by us because we get a lot of patients who are locally advanced or high risk prostate cancer. Since we do not do any screening program in India, they are either voluntary screening or they come because they have symptom. And 40% of our cases, when we operate them, they are either high risk or they have locally advanced prostate cancer. The things have evolved in this segment. I have no conflict to declare that by definition, there are many definitions, more or less they are same. Particularly the PSA has to be more than 20, Gleason's risk more than 7, like 8 to 10, and clinically T3 to T4. These are the main criteria for locally advanced or very high risk prostate cancer. What are the guidelines recommendations? If you see, the prior to 2015, most of urological society recommends combination of hormone therapy and radiation therapy as a preferred treatment option for such type of cases. However, EAU changes recommendation to include surgery as a part of multimodality treatment in selected patients since 2015. A small volume low volume T3 or PSA 20 or less or Gleason's 8, like this. But things have evolved further also, which I'll be showing in my slides. What has changed by 2015 is, surgical method have improved and they have become less invasive, and then you are not compromising with the radicality of operation even by robot. Robot has a specific role in such cases. You can do whatever the way the surgery you want by robot also in such patients, so that the morbidity is less and the continence part is better. How the surgery can help in LAPC is, one is by down staging. T3 disease, which is seen on MRI most of the time, we label as T3, but it may not be T3 in 20 to 30% of the patients. When you operate them, 20 to 30% of the patient, they get down staging. Previously, the thing was that we thought there is a disseminated micrometastasis, and we were thinking they are like uncurable. But then when these patients got operated, then they realized that even T3 disease was T2, and these patients did not require any treatment, any adjuvant treatment. There are other reasons for such patients, like the patients who have advanced disease and they are being offered surgery, not only prostate now, but you can see locally advanced breast cancer or ovary cancer or colorectal cancer when they are treated primarily by surgery. The reason is that deep DNA sequencing of tumor has revealed that primary carcinoma is the actually site from where the cells, they get separated and they go and cause the metastasis. It goes from metastasis site to other site also, but primary site is the one mainly which is responsible. And there's another reason that primary sites actually secretes many chemical which go to other parts of the body, and where they make a microenvironment which is favorable for the cancer cell to get trapped and grow there. This is called as seed and soil hypothesis. So theoretically, if you remove the primary, probably it will help in patients who have advanced disease in any cancer. But then in prostate, it is evolving. Now the surgery shows better cytoreduction and then RT. This is actually a debatable question. We can debate on this in literature. There are reports on both in favor of surgery, both in favor of radiotherapy. I think radiotherapy, Gagan will tell, but I'm just telling you how the things as on today are. But this segment is evolving. And this is the meta-analysis, a systemic review presented bioscience reports, and this shows that cancer-specific survival favored radical prostatectomy in comparison to radical radiotherapy. And same was overall survival in this report. And when they did sensitivity analysis, where they actually, all the study they combined, and one of them they removed one by one and then compared, then also it showed better outcome of surgery. So where surgery can be used, these are the places where surgery can be used as monotherapy. T3 disease on imaging, and it gets down stage to T2, where the PSA is less than 10, and Gleason's may be high, it may be 8, 9, 10. These patients will not require adjuvant treatment immediately, they may require later on, or some of them may not require at all. Where here the RP works as monotherapy, and the expected outcome in such patients has been shown that cancer-specific survival rate after RP have been 5 years, 85 to 100%, and 10 years, 57 to 72%. And overall survival at 5 years, it is 75%, and 10 years, it is 60%. But then our radical prostatectomy, mainly it is used as rest of the patients, who 70-80% of the patients who do not meet the criteria which I showed you in previous slide. And the expected outcome in such patient is 5-year cancer specific survival is 95%, and 10 years is 90%. This is the report, but then there are the new report also which actually favor that surgery can be a part of the treatment for locally advanced or high risk CA prostate. There are some two latest systemic review which have actually compared the radical therapy, radical radiotherapy, and radical prostatectomy. One is this from World Journal of Surgical Oncology. This I'll show you first, and this I'll tell you the conclusion. In the meta-analysis of WJSO, they have shown that RP showed more survival benefit than radiotherapy on cancer-specific survival, but RT was associated with better biochemical recurrence-free survival. However, brachy and DBRT performed similar to radical prostatectomy in terms of cancer-specific survival or overall survival. Subgroup analysis showed that the radiotherapy was associated similar, even marginally better survival outcome than the radical prostatectomy when the Gleason's was high and high T stage was there. But one should not forget, when you offer radiotherapy to such patients and when they do not fail locally, 18 to 20% of these patients will end up multiple surgical intervention for the urinary symptom or retention or stricture or something. The another review which I have shown you in the last but one slide, that EAU, European Urology Systemic Review, and they also showed in conclusion that both radical prostatectomy and radiotherapy as a part of both RP as a part of multimodal treatment, and EBRT and long-term ADT also can be used as long-term as it used as multimodality treatment, especially only in high risk and locally advanced prostate cancer. Then again, they made a comment that external beam radiotherapy with brachytherapy is also an option, but has higher grade 3 toxicity. They suggested one should shorten the ADT, especially if the patient has the comorbidity, and it is too soon to recommend the neoadjuvant hormone therapy, neoadjuvant chemohormone therapy, which I will be showing one report in my presentation. But then this another segment which is evolving before radical prostatectomy, giving neoadjuvant chemohormone therapy. And this is the report which has shown, actually compared the chemohormonal therapy in LAPC, and this was presented by James System and in 2019 AUA. And these were the demographic criteria, the clinical criteria. You can see the T3, T4 disease in RP alone, and ADT, docetaxel, and followed by RP was 77-60%, seminal vesicle invasion 41, 32, positive lymph 30 and 20, and positive surgical margin were less in ADT and followed by ADT, docetaxel, and radical prostatectomy arm. Please silent your mic. These are biochemical progression phase survival. You can see that here there is some difference. The chemotherapy, hormone therapy arm has done better, but it's not very significant. But if you go for freedom-free from treatment failure, it is statistically significant if the patient received neoadjuvant therapy. Overall survival also was not statistically significant. And this is another trial in ESMO, presented in ESMO last year. There is another trial, this is Radicals trial. This has compared adjuvant radiotherapy versus early salvage radiotherapy. And there is another radiotherapy trial where they have compared same thing in a Ravis trial, and they have come up that the adjuvant radiotherapy and early salvage radiotherapy, they are same. So one should not offer blanketly to everybody who had margin positive or some high risk feature straight away the radiotherapy. One should wait for the PSA to come up and should offer the early salvage radiotherapy. So with these two trials, two reports, we can definitely conclude that there is a clear shift in paradigm in the patients who are having LUPC or high-risk prostate cancer, that neoadjuvant therapy works. Radical prostatectomy can be performed with safely with good results, and radiotherapy can be avoided when necessary. It is not necessary to give in all patients, and ADT should be given only when it is necessary. Again, should not be offered to every patient. So what are the evidences for robotic surgery? There are multiple reports in the literature. This is review article from in 2018, and it has shown that there are multiple series, multiple surgeons have shown their positive surgical margin reports from 20 to 48%, and the biochemical recurrence-free survival. And these are the future trial which are going on this subject. Brian Chaplin is doing MD Anderson Cancer Center on overall survival. So in conclusion, it takes a message for the PG who have logged in as locally advanced prostate cancer are best treated by multimodality approach. Not a single modality will be enough. Surgery has role in selective patients, and whenever possible should be used. Still, most of these patients will receive radiotherapy and hormone therapy during their course of treatment. Thank you.
Thank you, Dr. Rawal. That was a wonderful presentation. There was a question from the audience. What is your experience about this locally advanced cancer?
As I told you, we have around 40% of the patients who are either high risk or locally advanced, and we offer them. Not every patient will offer surgery, will get surgery, but then if the patient has got sub-centimeter lymph node, and nowadays we are doing even PSMA PET scan also, that also showing sub-centimeter lymph node. PSA is not the criteria. PSA can be 100 even, that's not a criteria. Mainly the local characteristic of the disease and the lymph node status, the main criteria, and the patient's definitely is survival, how long he will live, comorbidity, they are the reason, but PSA alone is not the criteria. And then we offer them surgery whenever it is possible. And adjuvant treatment is always decided after the surgery. When the report comes, I never gave adjuvant radiotherapy. I always believed in early salvage radiation therapy. And this we used to have a lot of time debates in whenever we meet in Bombay or Bangalore. And nowadays, the trials are there. So everybody is now hopefully will offer early salvage radiotherapy.
Okay, thank you, Sudhir. If there is one message that comes out from his lecture, and that is a message, I think a very important message from this webinar also, that we are realizing that one modality of treatment is not generally adequate for high risk locally advanced prostate cancer, and most of the patients will either land up having two treatments, or right upfront will be planned for two modalities or maybe even three modalities. And as we go along, I think these issues will be discussed more and more. And now, after Dr. Sudhir Rawal, I invite Dr. Hemal. Dr. Hemal, I think I do not need to introduce him, but because he's an invited faculty, I'll just briefly tell that he is a professor in the Department of Urology at Comprehensive Cancer Center and the Institute for Regenerative Medicine. He is Director of Robotics and Minimally Invasive Surgery and Chief of Uro-Oncology at Wake Forest Medical School and Baptist Medical Center, USA. He has contributed several firsts in the field with focus on uro-oncology. He did the first robotic radical prostatectomy at All India Institute in our team in India when he was at All India Institute, and now he has been in USA. He has so many awards to his credit, and including Dr. B.C. Rai Award, UGC Hari Om Ashram Award, Padma Shri, and there are so many other things. I'll stop short here and hand over the mic to Dr. Hemal. Thank you, Dr. Hemal.
Good evening, Dr. Seth. Can you hear me?
Yes, sir.
Yes, sir.
All right. First of all, I would like to thank North Zone Chapter of USI and Dynamic and Versatile Secretary Dr. Anup Kumar and President Dr. Seth for organizing this meeting. And also I know the President-elect Dr. Rawal, Dr. Seth and Dr. Anup, they're pushing the envelope of developing uro-oncology in India. And I think that is a very great effort because uro-oncology is not a urology. And this is a different beast and different specialty. So I would like to congratulate you all for doing this. I have been interested with talking about the lymph node dissection in the cancer prostate for localized and advanced disease. All right, so the first of all, also I would like to acknowledge here, there are several teachers and several colleagues of mine who are now listening, and they're in AIMS. And certainly I give the credit to the AIMS, what minimally invasive surgery I'm doing today. And also I'd like to recognize Dr. Menon, besides our local faculty, residents, and fellow at our institute. So we started our robotic program in 2008, and we have done over 7,500 robotic procedure at our center. And in this, because I'm focusing only on the lymph nodes, so I'll be talking these, why we should do that, what should be the template, indication, and technique, complication. Now, when we talk about the lymph node dissection, which is a very integral and important part for the surgical management of prostate cancer. And lymph node is this sole modality which could reliably can tell you about the prognostic information about these cases, because that's how we get to know there is a lymph node invasion is there in these cases or not, as you heard from Dr. Rawal earlier. Now, there are different intent of doing a lymphadenectomy when you are doing radical prostatectomy. In some cases, it may turn out to be curative, but number of nodes removed are important in these cases. And also it has been borne out that when the lymph nodes are removed more than 10, there is a lower risk of cancer-specific death in 10 years if you follow these cases. Lastly, it is also important for the not only for the cancer-specific survival, but also it is important to do a current technique, which is oncologically necessary when you are dealing with the high-grade and high-risk cancer prostate. Historically, if you look in the previous literature, I mean, most of the patient, they had a positivity of lymph node ranging from 20 to 40%. However, with the stage migration in era of detection of the PSA, the lymph node positivity has gone down to 4 to 6%. But there were two reasons for that. One, urologists, they abandoned doing a lymphadenectomy for a certain group of the patient, and also it had not been performed appropriately, and only limited lymph node dissection was done in these cases. So what are the rationale for doing lymphadenectomy at this point in time? The currently available nomograms, whichever nomograms you say, MSKC, NCC, means MSKC or Pudendal or Briganti nomogram, still we are not yet there to correctly predict the lymph node involvement. Also, it helps in the better staging, and which is how you can do a risk stratification for these cases. Similarly, it helps in the accurate and reliable prognostic information. So when you are counseling these patients afterwards, you can tell them regarding the adjuvant and salvage treatment for these cases. Sometimes lymph node alone could be a curative for the patient who has a micromets in these cases. Indication for lymph node, if you go through the organization, basically AUA, NCCN, European Urology guidelines, but by and large, we follow the NCCN guideline. And if based on the nomogram, if there is a possibility of more than 2% likelihood of the lymph node metastasis, then you may want to consider doing a lymphadenectomy in these cases. Now, what is the lymph node drainage of the prostate cancer? That is also important, because lymph node, the metastasis from the prostate cancer is confined to the obturator fossa and the external iliac vasculature, which is by and large 40% of the primary lymph node satellite site is in these cases. However, if you try to incorporate the all tissue around the both external iliac vessels and also internal iliac vessel, you will be able to cover most of the landing spot of the these lymph nodes. However, when you want to do an extended or super extended lymph node, we have seen sometimes positivity in the presacral group of the lymph node. I have personally not done subaortic nodes, but it has been reported in the literature. What is standard lymph node dissection? In the standard lymph node dissection, as you know, usually you do take care of the extrailiac group of the lymph node, obturator group of the lymph node, and also you take care of the intrailiac group of the lymph node. So some of the literature describe it as a standard lymph node dissection. However, when you do talk about the extended lymph node dissection, in those cases, you take care of the intrailiac group of the lymph node and also the extrailiac group of lymph node, obturator fossa, and you go up to the bifurcation of the common iliac artery. And the most, if you are going to do a lymph node dissection, perhaps you want to consider extended lymph node dissection. The reason for that, by and large, most of the series they have reported that 40 to 58% of patients, they are located in internal iliac group of the lymph node. And what I have observed, people, they don't do a good job doing a dissection in the intra-iliac group of the lymph node, which is extremely important if you are doing a lymph node dissection. Now, what is the importance of the number of the lymph node removed? More extensive lymph node, if you have removed greater number of the lymph node, which has been associated with the higher biochemical recurrence-free survival in these cases. And perhaps by removing more lymph nodes, sometimes you can take care of the micromets in these lymph nodes. Also, more is better has been proved in another series where they found that the increased lymph node positivity rate is found more if you remove about 10 lymph node or plus. However, I would like to emphasize these can be performed very well with the open approach, laparoscopy or robotic. Certainly in our experience, the robotic makes us more versatile doing these procedures. At Wake Forest, usually we consider high intermediate risk, high risk, very high risk cancer prostate, in which we do an extended lymph node dissection, and in which we take care of the obturator group of the lymph node, external intra-iliac group of the lymph node, and we go up to the bifurcation of the common iliac. We have also found sometimes positivity of the lymph node in the retropubic fat. So usually when I do for the high risk or very high risk cancer, I do send a periprostatic or the retropubic fat for the lymph node evaluation, and we have found in our series in 0.8% patient this is a positive for the positive lymph node in this area. This is just a picture of the standard lymph node dissection. You can see the obturator nerve, psoas muscle, extra-iliac vessels. So basically, this is a standard lymph node dissection. But if you see the earlier series, people, they just used to take only the obturator group of the lymph node. Even they will not take the extra-iliac group of the lymph node. Now, this is a small clip to show for the giving what are the steps while you're doing a extended lymph node dissection. You can make the longitudinal incision. Here you can see the median umbilical ligament on the right side. And again, some of the literature describe if you do a lymph node first, sometimes you can get more lymph node, rather you can do at the end of the procedure, but both way it is okay. But the bottom line is you've got to do a good lymph node dissection. See, so here you are, removing the pack of the lymph node. This is the extra-iliac vein. You can see the external iliac artery. Another problem with when you do a lymph node dissection, there is a possibility of the lymphatic leak. So usually you may want to use a bipolar energy, or you want to use a clips in these cases. So for give a good lymphostasis, and here you can appreciate. Again, when you try to dissect this group, here you see this lymph node goes around the obturator nerve. So you have to be very, very careful. Usually here you get some perforator of the small vessels here. Now you can see the inter-iliac artery, branch of the inter-iliac artery, posterior iliac artery, and this is the superior vesical artery, inferior vesical artery. So this is by and large, this group of the lymph node is extremely important in these cases. Now we also used a fluorescence guided robotic lymph node dissection. And initially we tried to do a work for finding the sentinel lymph node drainage for the cancer prostate. And how do we do that? If you see the European literature, they used to give a technetium tag indocyanine green a day before, or through the transparent approach day before, and then wait for the 12 or 24 hours. We do it intraoperatively. Intraoperatively, you dissect the prostate and inject the dye into the prostate. You can see the prostate is green and periprostatic fascia is hypofluorescent. So that's how we did that. And this is what we found the frequency of the sentinel drainage and how much time it took to reach to this group of the lymph node. And we found this technique was sensitive in almost all the cases. However, the specificity was possible in 75%, but the negative predictive value was close to 100%. So this was our first series of 50 patients. And this is a small clip of showing the same technique. So you have dissected the prostate. Now you're taking the needle percutaneously. It's a 28 gauge needle. And we put only 0.25 cc on each side. So now that way prostate becomes green. Even you can do a radical prostatectomy with the indocyanine green dye. This is you can see the seminal vesicle Dye is not taken by seminal vesicle. This is the division of the prostatic pedicle. So you can see the prostate is green and rest of the tissue is non-green. So that way, even you can preserve all the periprostatic tissue utilizing the endocyanine green. And this is a dissection of the lymph node. In order to identify lymph node, you need to give at least 20 to 30 minutes before. So movement you do a dissection of the apex of the prostate, then we give. And based on this, we have also, moved on for the advanced cases. So say in this case, we did whatever the green lymph node we saw, we tried to excise all those lymph nodes. But after having done that, then we try to retract the sigmoid colon more medially on the contralateral side, and then we found more lymph node there. So sometimes you can see the mesenteric lymph node which is lit up by the endocyanine green. So this is another paper published in the World Journal of Urology utilizing the endocyanine green. They also found the sensitivity of 95% and negative predictive value of 98% with higher cancer detection. However, in the long-term follow-up, they did not find any difference in the rates of the biochemical recurrence. With this, we also moved for developing a personalized template for the pelvic lymph node dissection. And what we did for doing a personalized template for PLND, we take a PSA, Gleason score, grade group, PSA density, number of cores, and what is the percentage of core involvement. And based on that, you try to decide what subset of the lymph nodes in this particular individual should be taken care of. So you can also try to do, and now with the newer imaging, you can also map which area you want to do. Moving on to the last part of the salvage lymph node dissection. Again, at this point in time, this is being very well explored, but most of the goal in these cases to prolong progression-free survival, and we can delay the systemic therapy in these patients. Now, it again depends, salvage lymphadenectomy, but depends on the whether patient, when he was referred to you, whether any lymph node was done in these cases or not, whether a limited lymph node was done, standard lymph node was done. And based on that, it depends how much lymph node you are going to find and where you are going to find. It also depends what kind of imaging was done to figure it out it was there, whether you have done a PET scan or you have just done a simple MR imaging. Patient comorbidity is also important because really it's a difficult operation, it's not easy operation. And again, you have to see which area you are finding these involvement, and based on that, you can decide where all you want to dissect. But certainly you have to give a realistic expectation to the patient because this is not a game changer yet. And this is just an example of the, when you do the salvage lymphadenectomy, because these patients, they have already undergone previously radical prostatectomy, and again depends what kind of lymph node dissection has been done, and that lead to the fibrosis in that area. Now you can see all the scarring, and again depends, whether it's this case was done robotically priorly, but here where you are doing extensive dissection, you have to be really very, very careful. You should not injure the ureter. Here you can see the bifurcation of the common iliac artery, and this is the common iliac artery. Then you are trying to dissect you can see the vein is coming, but the tissue is very difficult to peel it out. So you have to use the monopolar pottery. So you have to use a diathermy to cut it through, because it doesn't peel off nicely because of the scarring. Now, if you see this tissue is going all around, and because this was enveloping the vessel, so it can be divided, then you can do the rest of the dissection again. So here you can see the extrailiac vein, and this is here now you're trying to dissect that part of the again lymph node. That's the obturator nerve there, and so really it's a challenging. Sometimes you can hit the vein. You can and your goal should be want to clean as much as possible. That is the purpose of doing salvage lymphadenectomy. You can see the small nick in the this area, which I repaired with the Pauline suture. And again, so this is just an example of doing a salvage lymphadenectomy, which is a difficult procedure. Now, this is the first paper published by the Montorsi for Sir Raphael, and what they found in these cases, almost 68% they had a positive lymph node, but the biochemical recurrence happened very soon, within 3 months in almost 1/3 of their patients. Similarly, this is a very good paper published from the Sloan Kettering, and what they found, it depends when you do a salvage lymphadenectomy, and if patient has not undergone lymph node dissection during his radical prostatectomy, almost 65% patient they had a positive lymph node when you are doing salvage lymphadenectomy. Whereas if there is a limited lymph node dissection has been done, then you find 50%. And if the extended lymph node dissection was done at the time of radical prostatectomy, then you find the minimal positivity of lymph node. So that again re-emphasized the point what I was making earlier. If you are doing a lymph node dissection, you may want to do an extended lymph node dissection. So basically, salvage lymphadenectomy at this point in time, it is feasible. However, vascular and lymphatic complications are high in these cases, and PF may be variable in these cases. You can also do in the cases of the oligometastatic disease, and due to want of time, I will not go in detail. And of course, you have to, the personalize or tailor the lymph node dissection based on the biological behavior of cancer in individual patient, and that you can plan accordingly. These are the general list of the complications which you can come across, and actually, this is the first paper. Bernardo and Dr. Patel are there, so they have published this first paper in which they did a CT scan in follow-up, and they found 30 to 50% patients, they may have a lymphocyte. However, these are not a symptomatic lymphocytes. So if you see this kind of lymphocyte, that does not require treatment unless symptomatic or it's causing a DVT or thrombosis. This is a paper published from the USC where they did a salvage lymphadenectomy in 10 patients. But you can see 1/3 of patients, they had a serious complication, including ecchymosis, foot drop, neuropraxia, etc. I'll just, due to want of time, I'll not go in detail, but this is one of the very good paper. I feel Dr. Briganti from the Serafel, they published. This is a 20-year audit from the one center. And what you see, almost the lymph node removal, what it was in 1990, and similar way there is being done even till 2010. And what they found, the lymph node invasion positivity was 26%, and now it came down to 15.6%, and that's perhaps due to the stage migration. However, if you do a good lymph node dissection for the high-risk prostate cancer, still the lymph node invasion is very high. So indirectly, it conveys that you may want to consider doing a good lymph node dissection for the high-risk prostate cancer and intermediate risk cancer. And as I mentioned to you earlier, the stage migration was perhaps the cause for the decrease in the overall lymph node invasion. However, lymph node invasion is still a significant, especially in patients with the intermediate and high-risk tumor. And stage migration does not justify omitting or doing just an obturator group of lymph node dissection. So this is very important. So in summary, what I would re-emphasize, it is important to perform extended lymph node dissection in the patient with the intermediate risk, high risk, or very high risk cancer prostate. Regarding the salvage lymphadenectomy, still I will say it is a work in progress. We are not yet there. And also when you are trying to do, always keep risk of the patient reasonable when you are doing these kind of procedure. With this, I would like to thank you for the opportunity. Thank you so much.
Thank you, sir. This was a wonderful presentation. And we can now move to the next lecture. Dr. Vipul Patel. So he will be talking about his experience, the lessons learned from the 13,000 cases of robot radical prostatectomy. So Dr. Vipul Hembal does not require any introduction. He is a renowned robotic surgeon across the world. He has been my mentor and has been mentor for many robotic surgeons. So today he's going to talk about his experience. So Dr. Patel, now you can please share your screen.
Okay, can you guys see my screen?
Yes, sir.
Okay, well, good morning, good evening. It's always great to see friends, and especially during this COVID period, everybody's stuck at home, but it's nice to see everybody. So I was asked to just give a little lecture about our experience with robotic radical prostatectomy what we've learned and what we're still learning. And so I'll start the presentation. So I've done over 13,000 robotic prostatectomies now. And so, you know, what we're doing here is every 6 months, we look back on the data of the last 500 or so cases. And then we also compare it to our whole retrospective cohort of the other 13,000. So I think the first thing we did well was we made sure that we had a very good, robust database with data collection and data analysts. And so this is where the data and the publications come from. Key is really the functional outcomes after the cancer. That's part of the talk today about technique. And these are some of the things that we've done. So I started this back in 2002. And since then, we've gone through a progression of different types of technique and incorporating different things. The key always is we looked at the complications, we looked at the positive margin data, and the trifecta and pentafecta outcomes to really analyze if we were making a positive difference or a negative difference. Some of the things we've done recently, I'll show, is we've modified our apical dissection. We take down less of the puboprostatics, and what that does is it leaves the urethral complex more intact. And so we think that influences the earlier return to continence. And so I'll show that in a little bit. Hope you can see this video well. As you can see, by leaving the urethral and apex intact, we can preserve these vessels that are feeding the sphincter. And so I think you have less devascularization, and therefore you limit your apical dissection. And so you preserve these arteries, these nerves, and so you create less neurovascular damage. So this is one of the things that we're doing more now. The other thing you do by changing your dissection is you preserve these accessory pudendal vessels. These are the nerve bundles down low, and up high you can see the accessory pudendals. Very important, especially when they're large, and especially in young patients. If you sacrifice these, you'll have some trouble with erectile function, no matter how good your nerve sparing is. But as you look at nerve sparing, it's really a calculation. You know, the most important obviously is the oncology, but the continence and sexual function are just as important in many ways to many patients. And so not every nerve bundle needs to be spared or can be spared. And so it's really calculating the judgment between when to spare and when the cancer takes precedent. We've published a lot on nerve sparing. I think many of us know the technique of our retrograde dissection, where we actually peel off the nerves before we clip the pedicle of the prostate. And the reason that's important is because it gives us the most accurate visualization of where the nerve bundle is. Some changes in technique over the last couple of years. In the past, we used to look, as you see on the left, we used to look for these things we call train tracks, where basically you would see the prostate removed and you'd see these robust neurovascular bundle, both sides going all the way to the apex. Now, we don't really see those nerve bundles. And the reason is, we actually, on low-risk patients, we go and we leave the lateral prostatic fascia still attached to the pelvic sidewall, so all those nerves are buried behind a layer of fascia. And so obviously, if those nerves are still buried next to elevators behind the prostatic fascia, we're hoping that we have less neuropraxia, traction, trauma, injury to the nerve bundles. And we studied it. We just got it accepted for publication in European Urology. And we found that by using the minimal apical dissection and the lateral prostatic fascia preservation, we had earlier return of continence and potency based on less trauma to the sphincter and based on less trauma to the neurovascular bundle. So this is our technique here, where we were 30 down and now I've gone to 30 up. This is XI robot, and you can see the prostate up above here. Down here's the rectum and the denominus fascia, and you can see there's a nice fascial plane there. You can peel this off. It's a very discernible plane. You're not in the capsule here. There's still some fascial layers on the prostate. But from Denalviers, there's a nice plane that goes over the top of the neurovascular bundle. And if you can get in that plane, you can actually peel the whole neurovascular bundle, Denalviers, and the lateral prostatic fascia down and leave everything buried laterally. And so this is the sparing of the right neurovascular bundle. And we'll switch over to the left side. Same thing. You see there's a nice plane. There's no arteries there. There's no veins. You get in this plane, you should have a nice peel. You're not too close to the capsule, but you do want to do this really mainly on low and intermediate risk patients that are good candidates for full nerve preservation. So once we release the posterior, we go anterior. Now we go back to 30-degree down. In the past, we used to make the incision out here laterally to find the levators. Now we go inside the lateral prostatic fascia. And you can see, use the scissors just like a paintbrush. Use it to peel everything down nice and gently. And the goal is that the lateral prostatic fascia stays attached to its lateral attachments. The nerve bundles are buried behind the lateral prostatic fascia, and therefore you have a nice spread. So here we'll go forward a little bit. There's your pedicle. So that's going to be your pedicle that will clip in a bit. So this is a retrograde approach. We release the bundle first, then we go to the other side. We do the same thing. I'll show that here. And the goal is really to clip the pedicle right at the base of the prostate and not to injure any of the neurovascular structures. That's the key to doing this. You can see here is the last clip of the bundle. The advantage of doing it this way is, we don't traumatize the neurovascular bundle as much. The bundle should be buried behind the lateral prostatic fascia. And we get a nice clean specimen. There's not a lot of bleeding. You don't need any heat. You don't need any cautery. You just need to do a nice gentle dissection. Then you'll go here, you'll release the lateral attachments, and then we'll see the end result in a second here. So what I want to show you is now that the prostate's out, you can see the lateral prostatic fascia here. You can see on both sides, the lateral prostatic fascia is still in place. And this is your fascial attachment right here. So levators are lateral, the neurovascular bundle is lateral, and you cannot see them. So that's our latest technique. In terms of nerve sparing, not every patient is going to have the perfect outcome. And so we've had Dr. Bhatt is our fellow from Chennai. He studied which patients we can predict the sexual function recovery on. And they're basically saying that in these patients, the amount of nerve sparing you do correlates with function. So if you do a perfect nerve sparing, they're going to have a better outcome than if you do a partial or no nerve sparing. The other things that make a difference for us are the influence of age and preoperative Shim score. You can see the younger patients have very, very good continence and potency outcomes, more than 90% in terms of sexual function and 95% in terms of continence. So what we found here is that potency is really dependent upon many things. How you spare the nerves, how much you spare, the age of the patient clearly correlates with outcome, and the preoperative Shim. If you do going in, but the older they are, the more of a hit they take. In terms of talking about high-risk prostate cancer, we recently published this in the British Journal, and it was really looking at how the practice has evolved in the United States after the 2012 task force decision to potentially limit PSA screening. And what we did start to find is that there was an increase in the amount of high-risk cases we were seeing, and there was definitely an inflection point. And so we basically studied all of our patients before 2012 and after, and we found that after we limited PSA screening, there was definitely an increase in the amount of high-risk cases that we were seeing, and a decrease in the better cases. So there was more unfavorable pathology. There was a decrease in bilateral nerve sparing, and therefore, obviously, the outcomes are also affected. Dr. Bhatt also looked at the outcomes of these patients before and after the task force. There was an increase in high-risk disease, T3, and also seminal vesicle invasion. And so what they found is that the rates of full nerve sparing decreased in order to balance the oncologic features of these patients that were more high risk. As you can see here, as we decrease the nerve sparing, continence, potency rates, trifecta rates started to go down. It's not because we weren't doing as good a job. It's not because we didn't have experience, but it was the patients we're operating on. The bigger the tumors, the wider you resect, the worse your potency outcomes will be. But obviously, it is a balance. And so we do need to do partial nerve sparing in some patients. And the question is how? How do you decide how much to do, how to do it? And so we teamed up with Dr. Rocco's group in Milan, and we went with the concept of nerve sparing is not all or nothing. It's a graded response to the tumor. And so our team, we looked at my data of 12,000 lobes of prostatic tissue, and we looked at the amount of extracapsular extension and the location. If you look at the standard nomograms for prostate cancer, really they have extracapsular extension. And ours was the first with a good AUC showing the location, the laterality, and the amount of extracapsular extension to expect based on your biopsy, so that during surgery, you can actually use that to your advantage. And so we came up with a nomogram showing left lobe and right lobe. You can see here on the left side, it's pretty much all clear. You can do a nice clean nerve spare. Whereas here on the other side, on the right side, you have to be at least 2 millimeters away from the capsule in order to get a clear margin. And so Dr. Rocco may talk about this later, but you can actually go online to Presi, nomogram it right at the bottom there, and you can push your data in there, and they can help you decide where to do your nerve sparing and how much. So this is a patient. You can see the prostatic arteries here. I'm using that as a landmark. We've published on that in the past, looking at the prostatic artery as a guide. If you don't spare the prostatic artery, you're going to get at least a 3 millimeter clearance on your margin. So this is a patient where we need at least 3 millimeter clearance of the margin on the right side, and the prostatic artery here is being used as a guide. But you can see he still has a good portion of his neurovascular bundle still remaining, and I think he'll probably have about 75, 60, somewhere in there of his neurovascular bundle still preserved. So that's very important to do that. So these are some of your landmarks. The nomogram told us how far wide we needed to go, and the artery led us to the amount. So you can see the artery there is still on the prostate. We have a decent amount of nerve tissue, but we have a lot of extra prostatic tissue that's still, neurovascular tissue that's protecting the bundle here. A few discussions about single port. I don't think that's in India yet, but we've been starting to do some single port prostatectomy, and it's different. You know, the single port robot, it doesn't have a wrist. It has a shoulder and an elbow, so it doesn't operate the same as a multi-port robot. And so there is a learning curve. It is challenging, and we're actually in the middle of doing a trial to study the benefits. I don't see at this point a huge surgical benefit to it. The pain scales are the same. The outcomes have been very similar. It does take longer operatively, and obviously it's a new robot. In the beginning, we used an assistant port on the side to keep our operative times low. We didn't want to take a 60, 70-minute procedure and all of a sudden make it 240, 300 minutes like it's shown in some of the literature. And so by adding the extra port, we were able to keep our operative times low. And there's the robot being docked. everything goes through one special trocar. And so we've probably done, 80 of these cases. We have a large experience, but I can tell you there's a learning curve for sure on this. It's not easy. It takes a procedure that you know well and makes you something you can do in your sleep, and it makes you start to have to think about every step. And so you can see here, the instruments look very similar, but everything has to go together. You have to have everything moves in a small group. So there's a little relocation pedal, and this has to be moved around. You can't go from one quadrant to another very easily. Clashing of instruments is an issue. I think single port has its role. I think if you look at version 3.0, it may only be a single port robot. We may not use multi-port, but this first version is adequate, but it has a significant learning curve, and it is more difficult than doing a standard XI procedures. So this is how it looks, and we can see his is a side view. So we put an extra camera in one day, and you can see here, didn't look like I expected it to look. This is our side view of the bladder neck dissection and how we're doing it. So, it's definitely a little different. As I finish off, I'm going to invite you to our World Robotic Symposium. It's going to be virtual. We expect somewhere between 3,000 and 5,000 people to attend. On July 31st will be the international session. So Australia, Asia, Latin America, Europe, and India will have their one-day sessions. And if you're interested in helping the India session, just talk with Anup. He's and Anant. They're a couple of my fellows. They're helping organize the India SRS for July 31st. And then we'll have the US version. So everyone will do their own, and then they'll plug into the main session, which will have faculty from all over the world on all specialties. We'll have urology, GYN, general surgery, head and neck, pediatric, thoracic, cardiac. So, and the plenaries, there's 24 new robotic companies that will present. So I think it'll be a huge event. Hopefully all of you can participate. Just touch base with Anup. And we're just arranging this now, so we haven't made any invitations yet. And so, yeah, definitely thank you. It's been a while since I've been there. It was a pleasure to get the BC Roy Award a few years ago. So good memories, and it's always a pleasure to speak to colleagues and friends in India. And hopefully once the COVID crisis is over, we all get to meet in person. Thank you so much, guys.
Thank you, Dr. Vipul. In fact, we had to introduce Dr. Vipul before the lecture, and that is how it should have been. But anyway, I'll just introduce Dr. Vipul before I introduce Dr. Bernardo Rocco. Dr. Vipul Patel, MD, FACS, he completed his medical school at Baylor in Houston, Texas. He completed his residency and fellowship training at University of Miami in Florida. Right now, he is working as the medical director of Global Robotics Institute at Advent Health Celebration and medical director of Advent Health Cancer Institute Urologic Oncology Program. He is professor of urology at the University of Central Florida. He also serves as a professor at the University of Milan, University of Korea, University of Lima, and recently has been made an honorary professor of urology at the Russian Academy of Science. So he's a general who wears so many hats, and he has traveled the globe lecturing and tutoring. He has educated thousands of surgeons, and you all have just seen his wide experience. He has done more than 13,000 robotic radical prostatectomies. He is also the president of the Florida Urologic Society and past president and managing director of the Society of Robotic Surgery. And you already have heard his welcome address for the upcoming Society Robotic Surgery Conference. Thank you, Dr. Vipul. Thank you for sharing your extremely vast experience of robotic surgery with us. And now I'll go on to introduce Dr. Bertrand Rocco. Dr. Rocco, we all know the Rocco stick. So there is actually very little to introduce him after having told you about the Rocco stick. there is actually still a lot to introduce about him. Dr. Rocco was born in Milan in 73. He graduated in 1998 from the University of Milan. He post-graduated again from Milan, and he's registered in the State Medical Board of Milan as well as Switzerland. He did 1 year research and clinical fellowship at the Global Robotics Institute, Celebration, Florida, from where Dr. Vipul Patel is the chief. And he has been working in the Department of Urology at Istituto Europeo di Oncologia at Milan. And presently, he is the chief of the Department of Urology at the University of Modena in Italy. And he's a full professor of urology at the same institution. He's also the scientific president for Italy of Europaumo, a European advocacy movement for men supporting prostate cancer. He has more than 180 articles indexed in Scopus and PubMed, and with an H index of 28 and 3,500 citations. I present to you Dr. Bernardo Rocco. Dr. Rocco, please. And the topic that Dr. Rocco is going to speak on is current perspective of uro-oncology case management in the COVID-19 pandemic. We all know that Italy has been one of the worst affected countries, and Dr. Bernardo Rocco has a lot of personal experience of going through this situation, and his guidance would be of immense value for all of us at this time of COVID-19. Dr. Rocco, please. Dr. Rocco, you have to unmute. You are on mute.
Can you hear me now?
Yes, we can hear you now.
Okay. Okay, excellent. Thank you so much. So I said that I would like to thank you very much for the kind invitation. I'm very honored to reach you virtually. And I am also very honored to give this talk after my mentor, Dr. Patel, that, as you mentioned before, has been my mentor more than 10 years ago, but is still the coordinator of the group I'm honored and proud to be part of, and still our referral point for surgical and scientific activity. So now the topic is, I would say, pretty recent, because we are talking about the current perspectives of the uro-oncology case management in the current COVID-19 pandemic. So I attended with a lot of interest Dr. Rawal talk, and he was giving us an overview on the situation of high-risk prostate cancer. So where did we stand with high-risk prostate cancer before the coronavirus happened? So 17 to 31% of men still present with high risk of local advanced prostate cancer, and the mortality rate is 28 up to 35% if untreated at 10, 15 years after diagnosis. There is no consensus about the optimal treatment options. The reason is that we have low quality studies on high-risk prostate cancer. I think this is a very interesting point, because we'll see that for low-risk prostate cancer, the quality of the studies is a little bit better, because high-risk prostate cancer studies are mostly retrospective or prospective observational. There are different definitions of high risk according to different guidelines, different radiation therapy schedules, dosages, and different ADT administration. So if you start with the definition of high risk, we have seen before that they are very different according to EAU, AUA, Austro, NCCN guidelines, including high risk or very high risk prostate cancer disease. So this makes comparison not very easy. This very nice review has been already presented, and there is no consensus about optimal treatment, but definitely is an interesting point. So retrospective series suggested an advantage for radical prostatectomy over radiation therapy, but the quality of the data included in this meta-analysis of 90 studies, the quality is not that good. So both radiation and radical prostatectomy should be seen as part of the multimodal treatment plan, with possible addition of radiation therapy, of course, after surgery, and or androgen deprivation therapy, respectively. High level of evidence for radiation include long-term androgen deprivation therapy. So when we consider radiation, we always have to consider that androgen deprivation therapies has to be included. So we might face both issues and complications with this kind of treatment. So again, comorbidity as diagnosis should be taken into account related to ADT. So we can say that as urologists, we can encourage results from radical prostatectomy as part of multimodal treatment. I strongly believe that surgery in this kind of patient has a very important role. And there is the advantage of avoiding systemic use of ADT because we can select patients that really need to have treatment or not to have hormonal treatment. And this, I think, would be a matter of interest after when we were going to discuss the case after this talk. Of course, there is the need of high quality randomized controlled trials, and the role of neoadjuvant therapy is under investigation. We are running a very interesting randomized controlled trial on neoadjuvant therapy in patients undergoing radical prostatectomy in high-risk disease. And this is absolutely the overview of the literature. But suddenly something happens, and we move from this reality to a COVID-19 environment. So what happened? In the 2nd of May 2020, you see that after 70 days, at least, I'm talking about Italy, this coronavirus started, he's spread all over the world. And here we have a time lapse of all the events that happened during this time. So the bottom line is that now we have more than 3 million people that got the disease and 224,000 deaths. You see that the distribution hardly hits United States and Europe, most than other countries. So what was the healthcare response against COVID-19? So moving from the discussion on what to do on the high-risk disease, suddenly it happens that we found an unprecedented situation for the modern history. And see in the picture, my assistant that was fighting COVID with all the suit that now we used to use to deal with these patients. The picture is of my department that only today and tomorrow will be again available for urology because it was just for COVID patients. So we had a care diversion towards COVID-19, beds, ICUs, and human resources. The general principle was avoid any unnecessary admission. This was a rule. We'd have to do only urgencies. The prioritization was a slowdown of non-urgent activity. It's something that seems like a movie. This is the very beginning of the pandemic, of the outbreak. So how did all this impacted on surgical volume in urology? So we quickly made an evaluation of the trend of surgical procedure during the first month from the beginning of the emergency. And we collected data from 33 Italian urological units. Just to have an idea, these units include facilities with 23,000 beds, and they were including 13 out of 20 Italian regions. Before the COVID-19 outbreak, the overall procedures per week were more than 1,200. Half of them were oncological. So if you look at this slide, you see what happens to our activity. The red line represents the activity, the reduction of the activity. So at the very beginning, we were full, zero reduction. But moving from the 22nd of February, the first case was diagnosed, to 22nd of March, we have a reduction by 78%. And if you also look at the continual full blue line, that was the amount of new cases diagnosed. You see that it's going much more than 40,000 cases. And the dotted line were the hospital admission that was growing. So we had an overall decline by 78% in this sample of 33 centers, as I mentioned. And if you look at the oncologic urologic surgery, then of course there was some discrimination between the indication. The reduction was by 35%. And it was pretty odd in terms of distribution in Italy, because in the area where we are, particularly in Milan, that all of you know, the reduction was up to 94% overall. So I think it's interesting to see this further slide. So what happens after 2 months, after the emergency happened 2 months after? You see that here we have the 78% reduction, and then there is just a gentle increase of the number of cases, and now we are at minus 64%. So we didn't have a steep reprise of our activity. We are still suffering a lot in terms of surgical activity overall. And of course, this raised a concern I mentioned that I am a scientific president of Europa Uomo Italy, that is a group of patients that refers to a European Europa Uomo. And on the BBC News, the association came up with could there be a major rise in prostate cancer death as a result of the COVID-19 pandemic? And I think that this is a very important question that we have to deal with. So the question is prostate cancer treatment time sensitive? So let's have a look of the results of the literature. So what is the impact on low-risk disease? Is it harmful? According to this study, no impact on BCR and clinical recurrence if we have a delay in the treatment. This is, of course, is a retrospective study. No risk if there is a delay. So what about the risk for intermediate risk disease? A study suggesting no impact on BCR and clinical recurrence. It's the same study as before, but we can see here there is a study suggesting there is some impact if the surgical delay is greater than 9 months. And this, I think, starts to introduce some point of concern. But what happens if we go to the high risk? This study from Dr. Gupta say no impact if the delay is by 6 months, but it becomes a problem if the delays goes up to 12 months, still in the paper mentioned before. So it's a little bit controversy if we can move on with our surgery and keep on hold the patients for a long time. So based on this data on potential delay that are published on the literature, let's have a look of what the guidelines say from the guidelines from urological societies mention on that. So with my assistant, Dr. Siginofi, and with the coordination of Dr. Patel, that I thank for that, we made this study that is in submission, where we compared COVID-19 guidelines from different urological societies. Are we all suggesting the same approach? So we are including some of the EAU, AUA, ACS, the English, USANS, NHS, and NCCN just in this slide, and they deal with different topics. None of them deal with the same, but they have some specific comments on the use of laparoscopy, or prostate cancer, and many other things. So they might be comparable. So let's have a look of the perspective in the settings that we analyze: screening, diagnosis, low, intermediate, and high-risk prostate cancer management. So there is a general consensus to postpone screening programs and to move to telehealth, virtual check-in, and remote monitoring. This found pretty much general agreement. But if we just start with prostate biopsy recommendation, of course, the high-risk disease have first to be diagnosed. So it's interesting to see that EAU suggests to perform, if possible, an MRI before biopsy. So it's the concept of a fusion biopsy still in place, even if there is the pandemic. Whereas the BAUS, the English, the British Association of Urology guidelines, suggest to avoid the MRI because the potential environment can be dangerous. So here we have an interesting point regarding these differences in terms of behavior. So coming back to the treatment of low-risk prostate cancer, there is complete agreement that low-risk prostate cancer have to be postponed. So we found of a certain interest that the literature on low-risk disease is very solid because it's based on the artery surveillance studies that has solid data. So we have strong evidences that in these patients, we can postpone the treatment without big risks. If we come to the intermediate prostate cancer, you see that there is a suboptimal agreement. As an example, you see that EAU suggests do not use neoadjuvant androgen deprivation therapy to postpone radical prostatectomy, whereas the Australian and New Zealand guidelines consider initial androgen deprivation therapy and defer definitive treatment. So here, that if we are in the middle, it might be hard to make the right choice and to follow this or the other guideline. There is an interesting substantial disagreement on the topic of this talk, that is high-risk prostate cancer during COVID, because the EAU panel, and I have to disclose that I have been part of it, but I don't want to see that this is my personal point of view, but just to disclose the fact that I was part of the panel who made the guidelines, say postpone until after the pandemic the radical treatment, the surgical treatment of radical prostatectomy. If patients is anxious, consider androgen deprivation therapy and radiations. The Australian and New Zealand guidelines say urgent surgical treatment for high-risk prostate cancer. So we believe that this is very interesting, that distinguished group of experts arrived at completely different conclusions, particularly in the settings of this talk. So we can conclude that the radical prostatectomy has to be considered as first step for multimodal treatment in high-risk prostate cancer. And this is, I think, the same conclusion of Dr. Rawal. This is in the normal environment. The COVID-19 is unprecedented pandemic event, required a great deal of care. The surgical cancellation or delay as a consequence deserves insight to prevent disease progression. Guidelines COVID-19 adapted have been timely issued, but are controversial because, of course, none of us has real evidence on what happens with COVID-19 and this kind of disease. Mostly are based on expert opinion, and this is the reason why probably there are some concerns and some differences between the guidelines. Impact of delay of treatment, and I think that is not clearly defined for all prostate cancer settings. And we believe that it would be very important now to sit and make a whole consensus from different urological society to drive surgical practice according to the time frame of the outbreak when different states are, and particularly now that we have to make the resumption of surgery, because we want, of course, to win the war with COVID, but we also don't want to lose the war with cancer. Thank you very much.
Great. Can I make one comment?
Yes, please, go ahead.
Yes.
Dr. Patel.
Bernardo, it's interesting. You were just talking about the AU guidelines and how AU said, you know, if it's patients high risk and they're anxious, then refer them for ADT and radiation therapy. A little bit different in the United States. Let me share this screen. See, if you look at the United States, the radiation guys are in the same issue as we are. They're saying that you should not initiate radiation therapy because the patient has to go in the hospital every day for many weeks. You should shorten the amount of radiation therapy. So avoid it, defer it, shorten it. So with the US, they're recommending do not do any radiation therapy if they're not candidates for surgery. Probably the high-risk guys, what we did. And so I'll show you really quickly what we did. So this is what we had in the United States. This is what we were expecting, a huge hit. And so we managed our ICU beds, PPE. I have 600 radical prostatectomies that are waiting for surgery. And what we did was, because we saw this, we knew that there were still surgery candidates. So I risk stratified them based on NCCN. So these are 585 of my patients for prostate cancer waiting surgery. very high risk, intermediate unfavorable, intermediate favorable, low risk, and very low risk. And so we re-stratified them, and we will start surgery again on tomorrow. And so we've been approved to go ahead and take care of the high risk and the very high risk. So we divided up our surgical team, and to manage these 600 guys, we overlaid COVID risk factors. These are all factors here that can have a patient have an adverse outcome if they have COVID. So if they're transplant, chronic lung disease, even though they're high risk, we've actually taken them off the schedule because of the fact that they're at significant risk from dying of COVID more than the prostate cancer. And so luckily for us, the curves are going down now, but we risk stratified them based on NCCN. We overlaid COVID risk factor, and we came up with the ones that will have surgery. So 200 guys will be prioritized to have surgery in the next couple of months. Then it will be the intermediate risk, and these guys low risk or on active surveillance. So radiation therapy in the United States was not recommended as an alternative to surgery during the COVID risk crisis, because they're under the same restrictions we are. So I just kind of wanted to share that with you. And so this is what we're doing on our end.
Well, if I can make a comment back, I completely agree with you. And but I think that the environment where the guidelines regarding the prostatectomy have been issued was an environment similar to the one I showed, where our OR for a couple of months had half of the OR was full of ICU patients. So when you have such a reduction, like 94% reduction of the OR availability, this means that you just can run urgencies. And that was the situation where such a guidelines happened. Of course, the access, 40 access to do radiation is much more risky than have the patient inside for 2 days. But if you don't have the chance of using the OR because it's full of COVID patients, in this sense, it turns out to be probably best to move to the other side. But I personally agree on the fact that if you have the availability of the structures, is safer to do radical prostatectomies, and in fact we are proceeding with our surgical schedules just for 30–40% compared to the usual.
Thank you,
So,
Dr. Rocco. We are over, we have lost about 15 minutes. I would request Dr. Hemal to make a quick comment before I hand over the mic to Dr. Anup for his case discussion, because he had 1 hour for the case discussion. I think he'll have to reduce the time to 45 minutes so that we can finish in time. Dr. Hemal, please.
all right. I guess, Bernard, a very good talk, but the two comments, the trial you mentioned, the pivot trial and the protect trial, based on both the trials, low risk cancer, intermediate risk cancer, they can very well wait, and it's not going to make any difference. For the high risk cancer prostate, the American Urology Association guideline, they recommend you can give a hormone treatment to these cases. You can give androgen deprivation therapy, which can last up to 6 months, and then they can be boarded for the radical prostatectomy in those situations. So these are the AUA recommendation. Now, question coming to, you are putting the patient for surgery. Now it's a COVID positive, because we are doing testing in all our patients, whosoever is coming to operating room. And if they're positive, then it is back to the same situation what we are talking. So I guess, as Dr. Patel pointed out, we have to be precisely very careful. It's not question of the patient, but he's infecting the staff, surgeons, then whole OR will be closed. So rather play safe in these cases.
Sir, any special precaution you are taking when you are doing robotic surgery in such patients?
Yes, so there are two things are important when you are doing robotic. Usually we are using an N95 mask, that is one. And second, also if you are using an air seal, you may not want to use a regular air seal, because these viruses, they can get stuck in the circulating system. So you want to use an air seal in evacuation mode. And also before taking out the port, make sure you have completely insufflated the abdomen before take out the port, so there is no leakage of the gas in the room or to the people who are assisting at that point in time.
Okay. Hello. Okay. Thank you all the speakers for wonderful presentations. Can you hear me?
Yes, very well.
Yeah, so I am going to present a case of high-risk localized prostate cancer because locally advanced cancer has already been covered by previous speakers. And we have a very elite panel of panelists here. Dr. Patel, Dr. Hemal, they have been my teacher and mentors. Bernardo Rocco, my dear friend. Dr. Anant Kumar, President of USI. Dr. Amle Seth, President of NZUSI. Dr. Raval is our President-elect of NZUSI. And Dr. Rajiv TP is our Secretary of USI, and then we have Dr. Gagan Saini, he's a radiation oncologist. So start the case. 67-year-old gentleman presents with a history of lower urinary tract symptoms for the last 6 months. He has got a hypertension, and on examination, DRE shows a right side hard nodule, grade 2 prostate. The PSA is 22, and ultrasound shows a prostate of 60 grams. So here comes the first question. This patient comes to us in a OPD. What should we do first, the MRI first or the biopsy first? So we start. These are the questions in front of us, and for the sake of urology residents, I have listed some questions for their clarifications. I start with Dr. Hemal. So Dr. Hemal, in this patient, you would like to do MRI first before the biopsy or biopsy first?
Well, if I'm given a choice what I should do, definitely I would like to do a MRI scan. But in United States, MRI scan is not covered by the insurance in the before pre-diagnosis setting. So some of the insurance may not cover. But if you are able to do an MRI, it's really good. There are several reasons for that. It's not only what lesion you are seeing, index lesion you can see, but you can also see more lesions or additional finding while you are doing the MRI scan. And it may be also helpful in the staging going forward in the future. And not only that, suppose it turned out to be a high-grade cancer. Now you want to operate, but you want to do an MRI scan to do an anatomical understanding. Then you have to wait 4 to 6 weeks to get an appropriate imaging study in these cases.
Okay. So Dr. Patel, in your experience, in your practice, what do you follow? You do the MRI first always before the biopsies?
Yeah, in Florida, we have a pretty good chance of getting MRI approved. So on all people that I'm going to do a biopsy, I do an MRI first. And the reason is a lot of these patients more and more are having anterior tumors that you cannot see on ultrasound. And those anterior tumors are usually the more aggressive of the bunch. So I want to make sure I have all the locations identified so I get a good sampling of all the abnormalities of the prostate, and especially targeting anterior tumors, which are not traditionally targeted on the normal biopsy. So I do MRI fusion on everybody, and I try and get an MR because there's a significant portion that are missed by just standard biopsy.
Okay, so that was my second question, that if you are doing MRI, you are planning for a systematic biopsy or systematic plus targeted biopsy or a MRI fusion biopsy. So as you already said, you do MRI fusion biopsy in all the patients. So this is what you're doing in all the patients, sir? High risk, intermediate risk?
Yep. We do our standard template, and then we target the areas of concern. The ROIs, we target them with at least 2 or 3 biopsies. The reason is, otherwise this guy keeps coming back again and again for another biopsy. We've had guys who've had 5, 6 biopsies outside without an MRI, and then you do the MRI and you see a big anterior tumor that was missed, and it's all Gleason 9, and we see it pretty commonly. So I think if possible, an MRI is helpful, and that's our standard in our practice.
We don't do a MRI fusion biopsy, and you also know from the data from the PROMISE trial, if you are doing targeted biopsy, in 25% you are going to miss the grade group 2 cancer prostate in these patients. So definitely, as Anup, you pointed out, you must do a saturation biopsy in these cases. You can do with the transparent approach, and we use a ultrasound. So we have a very high intensity ultrasound, and we use the cognitive imaging in a sense, and you can do a saturation biopsy in addition to targeted biopsy. As Dr. Patel also pointed out, sometimes you see the anterior lesion, which can be done very well with that, because with the transsectional approach, you may not be able to approach those cases.
So Dr. Rocco, what's your practice? Let us have the European perspective. What do you do?
So we usually perform the MRI before biopsy, of course. This case has a 22 PSA, has a positive digital rectal examination. So I'm not 100% sure that I would go to fusion biopsy, because we have a lot of waiting list on that, and this case is pretty straightforward in terms of potential positivity. But of course, it's useful to have an MRI first. It's important, I think, particularly now, to prefer the transperineal approach rather than the transrectal in this COVID time.
Okay. So Dr. Rajiv TP, now let us have some Indian perspective. What's your practice in your institution? Dr. Rajiv?
In India, we have to take two things into consideration. One thing is the availability of the MRI in the concerned institute or in the the patient's financial status, whether the patient can afford it or not, because majority of the patients coming to our government setups are of low economic profile. But if the patient can afford and the procedure is available, I definitely go in for an MRI, because it has got a lot of advantages, like it gives a good detail about the primary lesion as well as the local extent of the lesion. It is very excellent for the lymph node detection, then also can detect bone mets in the imaging area, and it can also detect other impalpable lesions other than, as you cited, it's a palpable one, and it will good guide the site of the biopsy and can avoid unnecessary biopsies and also avoid unnecessary waiting time for the biopsy. But if the patient cannot afford it, then our standard is to go in for a usual thrust-guided biopsy. That is the standard 12 core plus the palpable lesion.
Okay. So now we have the perspective of Indian, European, and US perspective. There's some advantage of MRI first, as talked about by our panelists, that you can avoid some artifacts and you can avoid some delay which is required after imaging. And it has been shown in this study that if you do the target biopsy along with systematic biopsy, as Dr. Hemal was saying, you can detect more cancers if you do both as compared to only targeted study. So that's the conclusion, that of course, if possible, MRI should be done first as per the EU guidelines. And if the MRI is positive, which is multiparametric MRI is positive, you should go for combined targeted and systematic biopsy rather than only a targeted biopsy. So I think this is consensus of all the panelists. So let us move forward. This is the multiparametric MRI in our patient, 2 by 2 centimeter lesion. You can see there in the right peripheral zone, pyrite 5. There is no extracapsular extension, no neurovascular bundle involvement, no seminal vesicle involvement, no pelvic lymph nodes. So, and then patient underwent systematic 12 core biopsy, and this is the biopsy report. Adenocarcinoma right side, 4 out of 6 cores are positive. Gleason is 4+4, IUSP group 4, and more than 50% cores are involved. On the left side, it is 1 out of 6 cores are positive, and Gleason is 3+3, grade group 1, less than 50% of cores involved. So this is the biopsy done. So now the question arises, how do we stage this patient further? We need to stage the disease, local nodes and metastasis. And the question is, should we use a PET scan, which is PSMA PET scan versus a bone scan? So now here's the question, what is the preferred imaging for lymph nodes and metastasis in these kind of high risk patients? So I will again start with Dr. Patel now. In his experience practice, if he uses PSMA PET scan or a bone scan for the staging purpose. Dr. Patel?
I think he's quit because he had another talk. I think he wrote that he was quitting.
I think so. We have lost his connection. So Dr. Patel, Dr. Himal, so what do you use as a imaging modality for these patients?
So basically, the way you said initially, because this guy had a nodule on the digital rectal examination, so we did know it is a cancer. Prostate possibility is extremely high given a PSA. So you have already done the MRI scan. So either you do a MRI scan in the beginning, perhaps that is much better, and that gives you enough idea about the lymph node staging. According to the guidelines, whether you take NCCN guidelines or AUA guidelines, there is no recommendation for doing a PET CT scan in these cases. Whether it's a choline-based PET scan or whether it's a Exumin PET scan or whatever it may be. So the PET scan is not indicated for the staging purposes. However, AUA guidelines does recommend if the PSA is more than 20, you can do a bone scan in these cases. But in personal experience, hardly you find bone scan positivity in these cases. If you have, because as Rajiv TP was pointing out, when you do a MRI scan in a cross-sectional imaging, even sometimes you can see the bony lesion in those cases. That gives you enough evidence to move forward with the bone scan or not.
Okay, so Dr. Rocco, what's your experience doing PSMA PET scan or a bone scan in these patients?
Well, I think that we have to do, of course, some staging for a potential M+ disease. And so far, we are using the PSMA PET that has a pretty acceptable sensitivity and specificity. And this is, I think, is good for M and N staging. But of course, I'm not sure that imaging so far is the best way to stage the disease. At least for metastasis, we don't have anything better. But for N+ disease, I prefer to rely on the nomograms and to use a cutoff to decide to do or not to do the lymph node dissection. So basically, of course, I do the PSMA PET and I take into account any positive signal on the N area. But anyway, I prefer to decide to perform or not perform dissection based on the nomograms.
So let's now have the Indian perspective. Dr. Anand Kumar is there. Anand Kumar, can you hear me, sir? So I think we cannot hear his voice. So Dr. Sudhir Rawal, sir.
Can you hear me now?
Yes, sir. So
okay, so see, there are two things in this patient. This patient is very high risk patient, 4+4, and 4 cores are positive on right side, and his PSA is 22. So definitely I will do PSMA PET scan, and we have seen in this situation, we have seen lymph nodes also, and even if you go to nomogram, lymph node positivity rate will be very high in this patient. So this patient needs a proper staging, and because he falls in a very high risk group, I will do PSMA PET scan, and I already have a MRI beforehand, so I will get an idea how is his plane, how are the lymph nodes, is there any indication of seminal risk involvement or not.
Okay, so Dr. Sudhir Rawal, sir, in your practice, you are using PSMA PET scan in all these patients?
Yeah, no, we are doing because it is very cheap in India, and but I have personal opinion that most of the time it doesn't change the treatment in such cases. But since it is probably better staging tool and is cheap, so we are using. If we don't do, somebody else will do, and it is very informative. But if you see head-to-head comparison, probably it doesn't change the treatment much, but it may help later on in follow-up also.
So as rightly pointed by our panelists, as per the guidelines, it only says you can do MRI for the local and lymph node staging and a bone scan for a metastatic staging. So therefore, a PET scan is not recommended by the guidelines.
Dr. Anup, can I please weigh in on this?
Yeah.
With your permission. Firstly, thanks for having me here. I'm Dr. Gagan, I'm radiation oncologist. I just want to bring to the notice of the panel a very recent publication in Lancet, I think in February or March, which is about 5 times change of decision making when you are subjecting a patient with high risk CA prostate to PSMA PET scan. So there is definitely some momentum and some weight in recommending a PSMA PET scan in a patient of our profile. That was my thought.
Yeah.
This is in Lancet in last month, I think.
Yeah, you're right, Dr. Gagan. So as per the guidelines, NCCN guidelines also does not recommend a PSMA PET scan, but most of the surgeons are using as per their convenience. And that's fine to highlight the MRI sensitivity is not good for extracapsular extension and seminal invasion, but still it is the best. We can further increase by using a multi-parametric MRI. And about the PSMA PET scan, it has been shown that it has more sensitivity than the MRI in picking up a lymph nodes, as already highlighted by our panelist. But again, it doesn't change our management, and that's the truth. But if you have a PSMA PET scan, you can use it. So in this patient, we consult the patient, we got a PSMA PET scan, and this was the finding. There was a 2 by 2 centimeter lesion positive in the right peripheral zone here. You can see there. Otherwise, there was no other lymph node or metastasis. So now it is a case of localized cancer prostate, as per the EA guideline, it become high risk group, and as per the NCCN guideline, it becomes very high risk group. So now my question to Dr. Hemal sir,
Yeah.
which risk certification you are using in your practice? When you classify this patient, do you use a NCCN guidelines or use AU guidelines?
Yeah. So Anup, your patient has a PSA of 22. He has a grade group 4 and clinically it's a T2A. So based on the NCCN guideline, it becomes a very high risk, and same with the European guidelines also. So you can classify as a high risk versus very high risk. So this case is a very high risk. Now you have to stratify the treatment for this patient based on the already you have done the MR imaging and PSMA, GA-PSMA, the PET scan. But the most important is you have to see what is the life expectancy of this patient, because the question is you are looking at only the biology of the disease, but you got to see the life expectancy of the patient. But if you go with the guidelines, NCCN guideline will recommend for this patient, he can have an external beam radiation treatment with the androgen deprivation therapy plus minus docetaxel for 1 to 3 years. He can also have the external beam radiation treatment, brachytherapy and ADT for 1 to 3 years. And best option is a radical prostatectomy with the pelvic lymphadenectomy. So in my opinion, in this patient, I would like him to offer radical prostatectomy and lymphadenectomy. There are a couple of reasons for doing that. Number one, you are also taking care of this patient as he was having a bladder outlet obstruction and he was having lower urinary tract symptoms. So it will your procedure will take care of the bladder outlet obstruction. Second issue is if his prostate is large, even you refer to the radiation colleague, they ask you to do a transurethral resection of the prostate to make the size of prostate small. So if patient is undergoing surgery, why not to take out the prostate itself? Number three, you prevent the local recurrence and the local symptoms, and also sometimes that can cause urethral obstruction that is also being prevented. Moreover, then you are doing a good lymph node dissection, because if it goes to the radiation oncologist, they do cover the lymph node field, but they are covering arbitrarily, and these patients are getting androgen deprivation therapy up to 3 years and having the side effect of the androgen deprivation therapy. So because of all the reasons what I mentioned, I would subject this patient to the radical prostatectomy with extended pelvic lymph node dissection.
As a part of a multimodality approach, this is what you are choosing, sir. I mean, that's
yes. So at our center, that is for sure. Any cancer prostate patient, he goes to the multimodality approach. We have a medical oncologist and radiation oncologist, and we have a multidisciplinary clinic. So this patient will be seen by all three of us.
Okay, so I just listed some of the treatment options just for the clarification of our residents. Now, ask Dr. Sudhir Raval that in his experience, what will he offer? Of course, as a urologist, you will have some bias for surgery, but let us hear his experience. Dr. Raval, what would be your choice? As Dr. Hemal has already enlisted his experience, would you like to do surgery in this patient?
Yeah, no, these are the patients where it depends, as Dr. Hemal has already mentioned about the life expectancy and comorbidity one has to see. And his one patient actually will benefit from the surgery. And the advantage besides what Dr. Hemal has mentioned, another is that you can tailor your treatment according to the biopsy report later on. If suppose lymph nodes are negative and then the margins are positive, but then you follow them and then you may not require radiation even. So there is no need to give all the modality in such patient. If the patient goes for radiotherapy, he will definitely receive hormone therapy for 3 years, which has its side effects. And if a bladder outflow obstruction is there, then again the surgery will be done, some kind of surgical procedure. So if the patient, such patient, they are actually should be offered the surgery. If they deny, that's a different thing. But in my practice, I always offer surgery first for them, and then if they go for radiation oncologist for discussion. But most of the time, our patients are like this only. When we operate them, they are in this category only.
So Dr. Gagan Saini now will bring you in the discussion. Now you are being a radiation oncologist, so I want to hear your perspective for this patient. What will be your choice, and then just brief us about your technique, dose, and extent in short for the interest of the residents also.
Thank you. It's always very interesting to discuss high-risk CA prostate in a multimodal kind of a scenario, in a modality, tumor mode, because there are many viewpoints for surgery which come up. So if you look at it from an evidence-based perspective, it is very clear that if you look at the aggregated results of CHIP trial, HYPO trial, and all the modern trials which have come in, and especially the although this patient is high risk on the Protectee trial, we will find that at the end of the day, the results for radiation and surgery are quite similar. There is a WJSO study which two esteemed speakers had alluded to, and it is very notable that radiation therapy leads to a better cause-specific survival in those scenarios, which I would probably interpolate and extrapolate to a similarity, because there can be no reason why something should be better. Having said that, whenever in a multimodality scenario, or whenever in a retrospective study or in a review of retrospective studies, a survival benefit is commented upon, it is probably being overlooked that what was the actual age of patients which were being recruited. It is often that in radiation oncology studies, the average age of patients is higher. So the overall survival data will always be a little skewed in that direction. That is my viewpoint. Having said that, this kind of a scenario, this kind of a patient, if surgery is thought about, if you think this is one of those few patients who can benefit from surgery without a positive margin, by all means, you can go ahead with it. However, the survival outcomes and the cancer-specific outcomes will be the same either ways in both the directions. So that is my submission regarding the perspective. Now we'll talk about the technique and dose, which is very necessary for all the people who have joined. The technique nowadays which has to be used for radiation therapy has to be image-guided radiotherapy. Image-guided radiotherapy means that during the course of radiation, the tumor, or rather the prostate, needs to be monitored depending upon the technology that you have. So we plan the radiation with intensity modulation, that is very focused approach to the prostate, with maximal sparing of the bladder and the rectal wall. And before each fraction, we will image the patient and we will make sure that the prostate is in the right place. We plan the patients with rapid arc so that the treatment gets completed quickly and intrafraction motions are not there. If one would have it, one should also go in for intrafraction imaging, and so on and so forth. So the point being made is a very simple point, that those needs to be focused on the prostate, and we need to monitor the treatment in an intrafraction manner. The dose that is given is about 78 gray in 39 fractions. And if we want to do, we can do some hypofractionation also in that, which is considered to be equivalent and not superior. It is equivalent.
Okay. So one comment can I make, Anu?
Yes, sir.
Yeah, Gagan, very validly, nicely you said. But you got to cover the lymph node template also in these cases. And you may want to cover the lymph node, whether you do a hockey stick or whichever way you want to do. That is one part. But I do
Certainly,
want to...
Certainly. Lymph nodes will get radiation. No doubt on that. I'm sorry if I missed that. But
yeah,
they will get radiation.
Yeah, that has to be covered very well. Number one. Number two, there are a lot of urologists online. So I want to mention, because most of these cases, they're not being followed by the radiation oncologists in the long term. And the side effect of the radiation we are seeing up to 20 to 25 years, 30 years. I have done in last 1 year, I have done 5 patients post-radiation fistula. I have to do a cystoprostatectomy on those patients. So these patients, they can develop secondary malignancy, they can develop fistula, they can develop severe lower urinary tract symptoms. Also, they will have a side effect of the androgen deprivation therapy. But I would like to warn also, this surgery is not a straightforward surgery. These are technically challenging. So the experienced uro-oncologist should perform surgery in these cases. That is also very important when we talk about the high-risk cancer prostate. It's not that you are doing 5 prostate in a year and you can take this case. Perhaps you may not want to consider this case. And these are the couple of things I wanted to highlight.
So Anand wants to say something. Yes, sir.
Yeah. See, there is a advantage of radical prostatectomy is that one thing that maybe around 30 to 40% of the patient, all the margins are negative, lymph nodes are negative, and you don't need anything more. In some percent of the patient, there may be micrometastasis, 1 or 2 lymph nodes positive. Probably you may not need anything more. If the PSA start going up and probably there is some local leftover metastasis, probably adjuvant or early salvage radiotherapy will take care of that, and you may avoid hormone therapy in majority of the patients. Even hormone therapy itself is not a very safe in long run because of the cardiovascular morbidity. If you choose the radiotherapy, hormone will definitely be there at least in this patient minimum of 2 years, maybe up to 3 years. And now we know that these can cause a severe cardiovascular possibility. So you can avoid the hormone therapy in quite a good number of patients in this situation. So, and what Hemal and others said, we have seen that you avoid local complication because prostate is out. And every year I do at least 2 to 4 every year for last 5-6 years cystoprostatectomy when the patient had radiation for various reasons, and they come back with the recurrent hematuria cannot be controlled, and some had a very severe pelvic symptoms and other complications, and we have to remove, and they had radiotherapy for either prostate or for colon cancer or for some other reasons. I had some of the females who had a pelvic radiation for other things, but and they had for many years, few years back, 5 years, 6 years. So that problem is also there, and it is well known, reported that bowel related complication is one of the most negative factor of the radiotherapy, and it could be 25 to 30% in long run.
May I weigh in? Dr. Anup, can I weigh in, please?
Yeah, please.
Sir, it is always interesting to discuss cases with you. Been doing that for many years, and I would just like to make a perspective. I'll share my perspective on this. Sir, it is often commented that these radiation-related complications are there and so on and so forth. But please try to understand, in this kind of a scenario where you will probably get a your 50% patients will end up getting some sort of radiation eventually. Ultimately, you are increasing the chance of toxicity by doing surgery. Now, I am not trying to advocate one modality over the other. Right now, I'm trying to make an academic comment about this patient getting. It's not as straightforward as somebody getting surgery, so there are no complications. Surgery, 50% patients getting adjuvant radiation, and so on and so forth. Regarding getting hormonal therapy is concerned, it is a fact that when you are taking salvage radiation, which will be probably the case in, if not 50%, little less percentage of patients, there will be hormonal therapy as well, ADT also as well. So ultimately, the number of patients who end up getting these adjuvant treatments, their probability of complications is so much higher. Regarding the complications of radiation that you mentioned, you people are all very esteemed surgeons, the top of the country, and certainly some complications will reach you eventually. All I can say in my humble opinion is that internationally, the more than grade 3 complications are reported less than 5%. And that's a very, very moderate number. And even in my series, whenever we have seen retrospectively, it's just that much. So you will see patients, yeah. but you will see them because you are so great surgeons.
Yeah, Gagan, can I make 2 comments? One is that you are right. With the latest radiotherapy, IGRT, we have seen that number of bowel complications are less. And one question I want to ask you, when you give salvage radiotherapy or you give adjuvant radiotherapy after radical prostatectomy, you give a small dose to a small localized area of the prostate to the prostatic bed. So will the radiotherapy complication in this image guided will be less. So these patients will have less problem and very few will require adjuvant hormone therapy.
Sir, you can just answer in brief because we have to run forward. Just no. 2 lines and then we
one sentence answer. Sir, whenever we'll do adjuvant or early salvage RT, Dr. Hemal will be very happy to hear that. I will always include the pelvic lymph node stations because it is very difficult to exclude them later. There are studies going on wherein you are doing it without pelvic lymph node stations and so on and so forth. But currently the guidelines say that pelvic lymph node stations need to be included in adjuvant or early salvage radiotherapies.
Okay, so now
even if the lymph nodes were negative.
Yes, please. Yes, please.
Okay, so Dr. Nado, so once you have decided to offer radical prostatectomy to these patients, how do you counsel this patient, and do you need any nomograms in these patients to counsel?
Yes.
So may I share the screen 1 second?
Yeah, I will just stop sharing. Okay. Right. You can share now.
Thank you. So if we have a look of the case, and that is the memorial slow catering nomogram. And so if we have to make a decision on what we do beyond the lymph node dissection, that is pretty obvious. We know that we have a risk of 88% of extraprostatic extension, but it's a general risk. In this case, it's more or less an advice not to stay close to the prostate. But in case this number is lower, it can be useful to have a site-specific extracapsular extension nomogram. There are 19 nomograms on prostate cancer. Only 4 of them give you the advice on what to do on both sides. So if we are able to do a graded nerve sparing, it's useful to know what is the site. So this is the Presi nomogram that Dr. Patel was mentioning before. And if you look here, there is the map of the prostate, that the usual one that we keep on the Da Vinci console. And here are reported the amount of positivity of the biopsies and the Gleason grade, T2B, age, and total PSA. So the output that we get is not this one, but just to explain you what you have to look at. So the lobe, the extraprostatic extension probability, and here the colors are decision rule areas that say stay at the level of the capsule or 1 millimeter, 2, 3, or 4 millimeters out of the capsule. Beyond probably is not necessary to have a specific information, but this drives you to stay closer or to stay in a wider field. So this is the case that we saw, and you see that the left lobe is between 50 and 60% risk of having disease at the level of the capsule. That becomes lower, of course, if you stay away from the capsule, and you are here around 20%, 18% of a probability of having extracapsular extension of 2, 3, 4 millimeters. So no nerve sparing on the left, and even worse on the right. The probability on the right side is 81.5% to having disease out of the prostate. That is very close to the 88% that we found in the Memorial's nomogram. So we rely on this nomogram that has an area under the curve between 81 and 90%. And we make a decision on how to keep distance with this nomogram. Thank you.
Okay, so let's go back to our slide. So as per the guidelines, it does not prefer one modality over the other. Radical cell prostatectomy or radiotherapy both are same as per the guidelines. And even if we choose that approach to use for radical prostatectomy, there is no difference between open, lap, or robotic. So let us see what happens in this patient. Because of the time constraints, I'm just moving forward with the treatment. So we planned this patient for robotic radical prostatectomy with extended lymph node dissection. Just a quick word about the nerve sparing in this patient. Dr. Hemal, would you like to comment? If you planned nerve sparing in this patient, what are your concerns about margins?
Yeah, let me, I heard, what I'm trying to say, the nerve is, when you talk about the high-risk prostate cancer, why you are doing surgery? First and primary goal is the biology of the disease. So oncologic outcomes should be prime in these cases before talking about the second thing. Second issue should be you want to give a continence to this patient. So my goal would be, I would look at the age of the patient. I would look at his SIM score or IIEF score before surgery. And also what is the quality of erection and what are the patient's primary goal. Based on that, I will decide the nerve preservation in this case. Based on the imaging report and the biopsy report you have provided, you can do a very well nerve preservation on the right side. Left side, I will not do a too aggressive nerve preservation because the nodule is there. And sometimes when you go for the surgery, a lot of visual cues provide you to what you should do. Because the reason is, say this guy has undergone truss-guided prostate biopsy. The biopsy needle itself can cause a local inflammation, local scarring, or if there is a hemorrhage, you cannot do a intrafascial or interfascial dissection. So I guess you may want to sometimes do a wide excision on the left side. So it depends, but I will try to preserve standard postal nerves if possible on the left side. Right side, definitely I would like to do a good nerve preservation in this patient. Even for me, say, suppose this patient says, I have a 0% sexual function, no sexual function. It's still, if a nerve can be preserved, I do try to preserve. So I don't go with the preset mind that I'm going to do a wide excision on the both sides. I may do a wide excision on the left side, but right side definitely I would like to preserve the nerves, and that also helps in doing a good dissection near the apex area, which will translate into good continence in these cases.
Okay, so Dr. Sudhir Rawal, suppose in these kind of patient you have a large prostate with a big medial lobe. So can you tell us some tips and tricks for the young urologist, how they should approach this case to avoid complications? Big prostate with a medial lobe in high risk cancer prostate. So
I
Rawal?
think, yeah, actually I learned from Dr. Hemal only. He operated one patient who was bimanually palpable in a thin patient, and he had a huge median lobe. After opening the anterior wall, you have to go laterally and see where you have to make an incision carefully, seeing the ureteric orifices. Many times median lobe may be a small or it may be very big. So sometimes it is so big that you may have to lift the median lobe with your progress or bipolar and see where the bladder neck is, so that you don't land up with a big bladder neck hole also. But sometimes you may land up despite of that. But then you may have to take a stitch of 2-0 vicryl on the lobe, so that you can pull the median lobe with the prostate and the prostate, and you can define the plane between the bladder and the pussy wall of the bladder and the prostate. So that's one thing which works very well. But you have to be very careful to see the ureteric orifice. You should not be very near to the ureteric orifice, should not land up with a big bladder neck hole. And if suppose you are near to the ureteric orifice, after removing the prostate, you should stent them before doing the anastomosis.
Okay, so Dr. Roku, would you like to comment upon the role of microscope and the resection of the margins from section in these patients? Have you used this in your normal practice?
Yes, so I ask the permission to share the screen again.
Okay, I will just stop. Yes.
Thank you. So the EAU guidelines suggest to tailor the nerve sparing to use the intraoperative frozen section. We know that this can be done with a regular frozen section or with the neurosafe approach that has been proposed by Martini Clinic. But of course, that is a very interesting approach. It's a very thorough approach, but not everyone has the lab that is equipped to do a neurosafe frozen section. This is very novel things that we are using since, I would say, 1 year or a little more, is fluorescence confocal microscopy. So this is a microscope. It's a very simple, it's like a photocopy machine, and you can grab a piece of tissue, you can put here in the slotted machine, and you can have a real-time image that is like H&E. Has a accuracy that is as high as a final pathology, and you also can do a final evaluation. So you see that this is the fluorescence confocal microscopy technology up, and here you have the H&E. So we can have a real-time evaluation of both borders. So if you look here, we can make a full flat side of the prostate that can be kept during the hemostasis. We can just flush with acridine orange, put in a couple of glass slides, and in real time, we can have the reading of the slide. You see, the pathologies can be easily away. So we did a live case with the pathologists in the United States because it's real time shareable with the pathologist. And we believe that this is a very interesting device, particularly now that we have problems with moving, and so telepathology might be implemented with this approach. Thank you.
Okay, so going back to the case, this is what we got in the histopathology. Adenocarcinoma of prostate, it was on the right side, there was a IUCP group 4, Gleason 4+4. On the left side was Gleason 3+3. There was a focal extraprostatic extension up to 3 mm on the right side posterolateral area, and the Gleason score of this extraprostatic extension was Gleason 4+4. There was no seminal vascular invasion, lymphovascular invasion, or PNI, perineural invasion. There was a focal margin positivity of 2 mm at the right side of peripheral zone, and all the lymph nodes were negative. So now the question comes, how to manage this positive surgical margin or extraprostatic extension in these patients. So this is my question to, firstly I will ask Dr. Amlesh Seth to comment upon this. What variables to take into account when you decide intervention in these patients? Dr. Amlesh Seth?
Yeah, the factors that one needs to take into account are what is the grade of the disease and what is the extent of the disease in the prostate, and whether the seminal vesicles are involved or not, and then whether the lymph nodes are also involved or not. So if it is a high grade disease, then one needs to go in for radiotherapy early. And if lymph nodes are involved, then one needs to go in for hormonal therapy early. And in this particular case, actually, I would take this as a small marginal involvement, 2 millimeter, 3 millimeter microscopic involvement. So it looks as if the margin is definitely positive, but it's a small margin positivity. The other factor is that Gleason 4 plus 4, 8. So because of these two reasons, one may consider early radiotherapy, but there are other factors which tell that early radiotherapy may not be considered, and that is that the seminal vesicles are not involved, and it has been a relatively localized disease. So in this situation, what I would do is I would get the PSA done at 4 weeks. If the PSA comes down to almost baseline level, then I will not advise radiotherapy. But if the PSA remains high, then I'll advise early radiotherapy. That is how I will manage this patient.
Okay. So I just want to highlight that if we talk about extraprostatic extension, you have to find that what is the grade of this extraprostatic extension. And if it is, you can see in the graph 8 and above, it has got a very low BCR-free survival. So it is very important to have this kind of reporting on your histopathology report. And as Dr. Seth rightly said, not all positive surgical margins will lead to a metastasis or a biochemical reaction. So this is the, I think, flow chart which has been recommended by most of the guidelines, and Dr. Seth rightly said, if it is high risk for biochemical recurrence, you have extensive positive surgical margins, you have, along with extraposterior extension, you have seminal vesicle invasion, then you can go for early adjuvant radiotherapy within 6 months of surgery. And if it is not a high risk, you can just wait. So now I just want to have the Dr. Gagan's perspective, the radiation oncologist, what he would like to add to this.
I totally agree with Dr. Seth sir that if we have undergone surgery and if there is these two factors, focal margin and this Gleason score, then maybe it's a good idea to see how the PSA is behaving and decide radiation therapy according to that. That's something. But may I make a comment that if lymph nodes are positive, then adjuvant radiation helps. Sir.
I'm just coming to that topic after this. Okay. So now, if you have a positive lymph nodes, how to decide the management? Dr. Hemal sir, if you have a positive lymph node in histopathology, how to manage these patients?
Well, so there are two comments for the earlier this thing. So for the positive margin, you can also do the NeuroSafe technique if you are doing a open radical prostatectomy. So the NeuroSafe technique can also be done for these to evaluate the positive margin during surgery, and also fresh frozen section, they're good. Now coming to the comment regarding the margin, as Dr. Seth pointed out, because the margins below 3 millimeter, they are considered insignificant margin, but that does not mean for the high grade, high risk cancer. This patient is a 67-year-old patient. He has a grade group 4 cancer. He has a PSA 22. I would follow with the PSA, but the possibility of having adjuvant radiation or salvage radiation is extremely high, because that you should see according to the longevity of the patient. So usually at our setup, if patient is young, below 70 years of age or 65 years of age, these are the patients, they are high likelihood of requiring adjuvant or salvage going forward. And that has been very well said in the BOLAS trial. And there, I think radicals is going on at this point in time, and we'll have more data with that. Now, question coming to the lymph node positivity. Now there are two issues. So this guy has a margin positive and lymph node positive. So these are two issues. So in this case, I would like to give an androgen deprivation therapy. In addition to that, I would like to give a radiation treatment, adjuvant radiation treatment.
Okay, so Dr. Rajiv.
No, sir, he has margin positive, microscopic, 2 or 3 mm, but his lymph nodes are negative. His lymph nodes are negative.
Okay. So if the, no, in those cases, as you rightly pointed out, you can see for the biochemical recurrence. So the definition of the adjuvant versus salvage, if you are giving radiation within 6 months, that's adjuvant. So still you can follow with the PSA. You very rightly pointed out you should do a PSA in 4 weeks or 1 month. Usually we do in 6 weeks, 3 months, and 6 months. So this way, indirectly, you are also seeing the doubling time if you want to see. But there's no rush for giving a radiation in these cases right away.
So Dr. Rajiv TP, I just want to ask you, if you have a positive lymph nodes in your histopathology, how do you manage this patient? What are the factors you consider while making any intervention in this patient? Dr. Rajiv TP?
There are certain factors based on which we advocate adjuvant treatment in pathologically positive nodes. First of all, it is the number of positive nodes that has been found. Second is the tumor volume inside the positive node. Thirdly, whether there is any extra nodal extension and percentage of positive nodes. These are all risk factors for a BCR relapse. Suppose, as already highlighted, if the number of nodes are less than 2 and there is only microscopic invasion and the PSA at 4 weeks is less than 0.1 nanogram per ml, and there are no evidence of any extranodal extension, then you can very fairly go for a expectant management, that is observation. But otherwise, if the tumor volume is more or the number of nodes are more, or is there any evidence of extranodal extension, as Professor Hamel has highlighted, two options are there. Either you can go for an adjuvant ADT plus this additional radiotherapy, or adjuvant ADT alone.
Okay. So, as you already rightly said, we discussed with the patient and we advised both the options, like early adjuvant or a salvage one, but patient has chosen for the salvage radiotherapy. And this is the PSA you can see at 4 weeks, 0.08, 3 months, 0.1, at 6 months, it is 0.4. So this is the scenario at 6 months, 0.4 PSA. So that this is, now we're talking about post-radical prostatectomy biochemical recurrence. So now, before I go to that, I just want to ask Dr. Hamel that there is a concept of persistent PSA after radical prostatectomy. So just want to clarify for the residents what is the difference between this as well as the biochemical recurrence.
Yeah, so that's a very good question, Anup. So that's why Dr. Seth was pointing out you should not rush for the treatment. So you should do a PSA. So as you rightly did a PSA in this case, this guy was having 0.08. The next PSA was 0.1. So the doubling time is I think it's less than 6 weeks. The next PSA was 0.4. So if the doubling time, that is most important, because even in some of these cases when you are doing surgery, if you leave some benign apical glands, they can also exudate the PSA. Also, sometimes if you left behind the tip of seminal vesicle, that can also give rise to the PSA. So you should work on the doubling time and PSA velocity. That's very important before making a decision. So your case clearly shows the doubling time is less than 3 months. Perhaps I would like to offer him an adjuvant radiation treatment.
Okay, so now Dr. Bernardo, I just want to bring you into discussion. How do you manage this patient of biochemical recurrence?
So I think that the key, as Dr. Hamal said, is basically the PSA doubling time. And first, I guess that is I consider this the most important parameter on decision-making plans on the way the disease will behave. Again, we come back to the PSMA PET that is still, if you consider this year EAU guidelines compared to last year EAU guidelines, you see that PSMA PET has more credits, and also on low PSA has a percentage of positivity that is not negligible. So I think that it would be good out of 0.41. That is, if I don't make a mistake, was the last value of our patient. I would move for that in the side.
So Anup, I can make one more comment. So this is not the case of isolated biochemical recurrence. This is a case with positive surgical margin. So you've got, so you need not to worry about the PSMA test. Also, PSMA PET scan will not show anything when the PSA is less than 0.5. So ideally, most of the cases when you have PSMA, PSA 1.5 or 2, then you see the positivity on the PSMA test for the choline PET scan. So,
well, if you look at the latest results of sensitivity of PSMA PET, I think that also at the 0.4, 0.5, the sensitivity is not negligible. I don't know if you have some data on very recent results. That, yeah, so it's it's 45% detection rates below 0.2, between 0.2 and 0.49. So I understand that we have a margin, of course, but anyway, we might still have potential positivity out of the area of the margin. That is, of course, the major focal part of the disease.
Okay, so I'm just highlighting here the sensitivity of PSMA PET scan as per the PSA value. And you can see if it is less than 0.2, it is less sensitive, but as it increases to 0.2 plus, the sensitivity increases. So now this patient had a PSMA PET scan. There was no active lesion in this patient. And therefore, as rightly said, we went ahead with the radiotherapy and ADT. Now, here I would like to ask Dr. Gagan Saini, how much radiotherapy he would like to give and how much ADT he would like to give in this patient.
Yeah. So, Dr. Anup, can I make a couple of comments? First things first, in a lymph node positive scenario, I don't think we should wait for PSA rising, although this is not what you are discussing. That was a theoretical or rather hypothetical extension of the case which was discussed. But just to make the record clear that in such a situation, I would certainly not do it, because doing radiation therapy in an adjuvant setting, in a classical adjuvant setting, has a survival advantage. This was proven with a very good trial published in JCO in about 5 years back. Now coming to your question, the dose, as is even shown on the slide, is between 66 to 72 gray. And this 66 to 72 gray, such a wide margin is there because there is a lot of empiricality when we are giving dose. We may want to, if it is favorable, the anatomy is favorable, we may end up giving a little more dose. And if the anatomy is not so favorable, we may end up giving a little less dose, but it should not be less than 66 gray, as radicals and the artistic meta-analysis have amply proven. May I make one more comment, Dr. Anup? It's only a single sentence comment, with your permission. I would just like to say that biochemical recurrence, if we are thinking about PSA dynamics to decide on adjuvant treatment, then we must follow the trials which have defined it for us. And that is the artistic meta-analysis and the radicals RT trial. And that is about 2 rises of 0.1 nanogram or a single rise leading to more than 0.2 nanogram. So these are the things which should form so that we can actually give the similar results as of not giving adjuvant RT. The idea of giving early salvage is that you should give equivalent results as adjuvant RT. And these are the things we should follow when we are selecting patients for that. So we cannot really go on and on just following PSA. I mean, I'm not saying that anybody suggested it, but sometimes we see it, that sometimes it goes up to 0.7, 0.8, 1 point something. Then that is not giving the same results as adjuvant RT. Then we are looking at different results.
Okay.
Just a point.
Dr. Anand, sir, if you get this kind of patient, your practice will be same, or you want to differ with whatever we have discussed here?
This patient will definitely go to Gagan Saini, and I have been sending such patient to him, and I agree with him whatever he said. This patient needs adjuvant radiotherapy, and that will take care of him.
Yeah, I think so. That's what we did. We referred patient for radiotherapy, and he received salvage radiotherapy with 2 years of ADT. And this is what we have at 1 year follow-up. This is under control now, still undergoing treatment. So here I would like to conclude this case by saying that when you get a high-risk localized cancer prostate, it has to be shared disease with the proper patient counseling. It has to be multimodality approach, whether it's a surgery or radiotherapy. Alone, modality cannot be sufficient for that patient. It has to be good preoperative planning for nerve sparing if you want to do nerve sparing in this patient. And you can achieve very good functional and oncological outcomes with a robotic radical prostatectomy. I think this we all will agree as a urologist. But the rigorous follow-up is mandatory. So here I would like to conclude this case, and I want to thank all the panelists. They have really participated so much, so excellently in this debate, and they have expressed their views, and also the audience. So now over to Dr. Seth, sir.
Thank you very much. We have already overshot by about 15 minutes. So I must thank everybody. I must thank all the faculty. I thank all the participants. And it has been a very good, very great discussion. And we have finished more or less in time. We have gone overboard by about 15 minutes. And thank you very much. Thank you, everybody. And hopefully we'll have another fruitful discussion as early as possible. Thank you very much.
Thank you, sir.
Yeah, Dr. Hemal wanted to say something.
Thanks to North Zone chapter for organizing a great web meeting. And also it was great to see Rajiv PP, versatile secretary of USI, and Anant as always, vocal. All right, have a great evening. Good night.
Thank you, sir. Thanks for
Bye. Thank you so much.
Yeah, thank you everybody. We have benefited
Thank
a
you,
lot from the
everybody.
experience of
Anoop?
all the panelists. Thank you very much. Thank you.
Anoop?
Thank you.
Thank you. Thank you. Thank you.
Anoop?
Yeah.
Yeah, can you, I think this will be good if you put this webinar on USI website.
Yes, sir.
Sorry, USI TV, so
Yes,
that people can even access it later on.
Yes, sir. I will put it, sir. Thank you. And
Yeah.
Dr. Sudhir Raval, you want to say a few words? Dr. Sudhir Raval is there? I think he's left. Okay. Thank you.
Okay, thank you
thank you,
very much to everybody. Thank you very much.
Good night. Good night.
Light has gone at my area.
Overcut.
Okay, thank you.
Thank you, sir. Thank you. Bye.